So the topic is implant placement with simultaneous GPR in the mandible. Okay. As I have shown you yesterday, implant in the posterior mandible, that's about 40% of our situation. And with the reduction of the crest, we can often bypass the GPR procedure. And using the small diameter implants also helps us, but not in every case we are successful to do so. So therefore we need to analyze the anatomy, and I showed you yesterday some of the studies that show that the height is normally pretty good. The width might be a problem. Okay, then we have defects in the mandible. It's the same as in the maxilla. We make a differentiation between two wall defects and one wall defects. When a posterior mandible is atrophied and we have about 3 millimeters of width, or 3.5 to 4 millimeters, then the resulting defect will be a one wall defect, and then we cannot do a simultaneous GPR. Today I only talk about simultaneous GPR. That means there is enough bone width to have a two-wall defect. And that's what you see here on top. That's here. That's a two-wall defect. That's a one-wall defect. So implant is outside the bone. So you should not place implants in these situations. Okay, very important differentiation. Okay. What are the important aspects for decisions? You analyze the width of the crest. You analyze the shape. Is it like this? Can you reduce the crest to improve your situation? Very important. And then the third one is the diameter of the implant. Reduce the diameter gives you better chances for two more defects. So that's a very important aspect as well. So we have then the different treatment approaches. Again, it's based on the patient anatomy. Here are the risk factors, and here are the treatment approaches. And then we have different timing protocols. And again, in the mandible, you could have an immediate placement, early placement, late placement. Same technique. Are we using immediate implants in the mandible? Never, because that doesn't work. There are ITI fellows who have been using a lot of immediate implants. The most prominent one was Tom Wilson in Dallas, Texas. And he always told me, you are too conservative, you should do immediate implants. I said, no, come on, forget it. I have done a few cases, didn't work. When I was in Dallas 2 years ago, he said, Danny, you are absolutely right. I completely stopped to do immediate implants in the mandible. I have seen so many bad complications with biologic infections later on. So that doesn't work in the mandible. So actually he at least learned it. So when we have the treatment options available, as I showed you before, you see I'm not using immediate implants in the posterior mandible. That's mainly for premolars here, few sites here, but not here. That doesn't work. Okay. So what are the surgical approaches? When we have small teeth and we have a fatal defect, we go rather short. 4 weeks is quite often. A premolar extraction, 4 weeks later I go in to do the surgery. When it's a first molar, we normally go for early placement with 4 months of healing. Too often socket grafting, and then we can bypass GPR quite often. So we have reduced a lot of the GPR procedures lately in the mandible by doing so for first molar sites. So let us start with early placement, soft tissue healing, 4, 6 or 8 weeks. And I want to show you a case I did many years back, so it has not changed. So this patient came to me and she has had here a loss of retention because of caries at this premolar. And you can also see that this tooth has a problem here. So that's what we did. So I took the premolar with the caries out. And I also removed the first molar. So you see here the molar extraction and the premolar extraction. At 4 weeks of healing, we went back in, open flap procedure, and you see now that in this area, this is an early placement into a non-healed extraction socket. But you see, we get a very nice two-wall defect. Today, probably, I would use here even an NNC implant, because a premolar NNC, perfect. Strong implant, smaller diameter, tissue level. And the second implant we placed here was a standard implant that was placed in the heel side. The socket is here, and mesial to the socket is enough bone to have a standard implant placement. You just put it slightly deeper, because as you see at the top, the bone is rather thin, but it's getting wide very quickly. Today I might even take that off, but that surgery was done 14 years ago, 2004, if I recall correctly. So the implants were placed. You see then the first implant. The premolar implant was augmented the same way. Very important now, you see, very important, that this is a two-wall defect, and as you can see here, the defect has a horizontal component. When you put implants in the mandible and you put a GPR with bone grafts, see, there is a certain risk that the fillers glide apically. So I always say gravity in these situations is your enemy. So when there is a defect, make sure there is a horizontal component, like a balcony. Because when you put the bone in, there is a balcony, so it sits down, cannot glide further. Very important. So often I take a little diamond drill and refresh the bone. Make a balcony, as you can see. I will show you later in another case. So that the torture bone goes in, so it cannot glide down. And then the bios on top. When there is a certain risk to glide down, I take a fibrin sealant to stabilize. Sometimes I use tacks, 2 tacks, to stop the filler to glide down. Then the membrane and then a primary closure. Here you see the primary closure. 8 weeks later, the reopening. You see the second implant, the first molar implant is a non-submerged healing. The first implant, the premolar implant, is submerged because we used GPR. And then you see the reopening is done with a mid-crestal incision, and you move the keratinized tissue to the side. This is not a punch. Punch is used in the maxilla, but not in the mandible. Mandible, you maintain keratinization as much as you can. Mid-crestal and move to the side. Take the healing cap off, put a longer one in, and then you let it heal. Very quick healing. So that will work beautifully here. Okay, this is the patient 10 years later. 10 years. Look, this beautiful bone situation. This was the GPR case. This is the standard placement. You see little mobility, a little bit remodeling here. 3-unit bridge, screw retained. Okay, this is the case I showed you yesterday, just that is the BLT 2.9 millimeter. BLT 2.9. And you see the patient was referred to us with a single tooth situation here for lateral incisor. And when you measure this, this is less than 7 millimeters, probably 5.5 to 6 millimeters, mesiodistal space. So you've got to be very careful. You cannot use a standard diameter implant. Even an NNC implant is a little bit much. So then I like to use a bone level implant, because then the abutment starts from the inner surface of the abutment. of the implant. And we made a decision, we go here with a BLT 2.9. You see the tooth was pulled in private office, so I got the patient already with the extraction done. See, it's very nicely healed. When we opened up, you see the remnant of the socket. So you see a minor defect on the buccal, it's not much. Not much. So we do an implant bed preparation, and you see also when we prepared this, we put it in the depth gauge, we take a radiograph. I want to see where we go. I realize I have to change direction a little bit. So we changed that, and then the implant was placed. So you see there is enough spacing to the mesial root and to the distal root. The buccal defect is not really big. Then we put a healing cap in. I have to say I don't like these healing caps. They are too bulky. I would love to have a slimmer one. So here you see that when they developed that implant, they did not consult with me, because that was done recently. And they have done these implants mainly based on feedback they got from the United States. And these people are not placing the implants deep enough. They put a bone level implant to the bone crest, which is a big mistake, because it has not a machine surface. When you put a bone level to the bone crest, you're going to get resorption, and then your micrograft surface is in the sulcus exposed. Don't make that mistake. Put them deeper. When you get the bone level implants, hopefully, with a machine neck, then of course you can put them to the bone crest. Then that problem is solved. Okay, so that's why I had a problem to really fit that healing cap in. It's too bulky. We have done an buccal augmentation, minor augmentation. This is what you see here, this whitish tissue. That is the fibrin sealant. It's called TIS seal. It's from Baxter, United States. It's a very nice, it's a fibrinogen and thrombin. You mix together, immediately coagulates, stops then the filler to move around. It's a stabilization factor. So we do that quite often in the mandible. And then primary closure. In this case, I did not use a membrane, to be very honest, to save the money for the patient, because of such a small defect. Okay, and here you see now the patient at reopening at 8 weeks, and you see the patient at the 1-year follow-up. Beautiful outcome. Here you see the radiograph that looks actually pretty good. BLT 2.9. It's a very slim implant, very slim. Okay, now sometimes we want to wait 4 months, and as I said, this is done on purpose. And sometimes you get patients, the extraction has been taking place, and when you get the patient, actually it's already 4 months have passed, then you cannot influence that. Okay, so this would be a case where you do that on purpose. And also that's a case more than, I think, 2004. And I showed you yesterday this, the patient with the computer-assisted surgery. Today we would do a case like this with socket grafting, computer assisting. That means then you have the no flap elevation anymore. So you see how we did it at that time in 2004. You always remove these teeth with root separation, very important. So separate them so you get 2 roots off like a premolar root. So you can limit the trauma to the site. Okay. So we put here in this case collagen plug. Today I will do socket grafting for sure. What I want to show you, this is a 4 months post. Little reduction in keratinized tissue. That could not be done flapless here. Because when you do flapless in a case like this, you're going to lose the keratinized mucosa on the buccal. That's not a good idea. But you see, when it opened up, we have a nicely healed situation, and we do a little smoothing. And then when the implant bed is prepared, it's a standard placement. It's not with GPR. So that is the technique we used at that time. Today we do socket grafting, and most often we can do flapless. That's a big advantage. And you see here the patient 2004, that was an SLA surface, not as selective. Reopening, here you see then the follow-up of the radiographs. You see here, this is in January, 4 months later, implant placement. And then another 4 months later, we have then the implant placed. Here you see the implant inserted, that's a 4-year follow-up. Other case. Now this is a case where we have had on the buccal aspect a defect. So the patient was referred to me. This is actually the lady I showed you before, then the early placement in the maxilla. So that was the lady, she got the first implant here, another one here, now the third one here, the canine. So this is 15 years ago. So then at that time she was just about 61 or so. She's now 76. And you see the tooth had a lot of caries, and we could see that here, in this area here, was a defect. So I took the tooth off, put a collagen plug in, and let it heal. And you see, the healing was not uneventful, because we lost a little bit of tissue here, and it took time then to fill up. So this is then 4 months later, that's like this. And when we open it up, you see, we have still had this remaining defect. So that's the defect we had. So, big diamond drill, smoothen it, very important. Implant bed preparation, and then you clean out the granulation tissue in the defect to see what is the defect. When the defect has an intact buccal plate, then I do often autogenous bone, bios, no membrane. I don't spend the money for the patient with a membrane, because we overfill it because the buccal wall is intact. That's what we did in this case. So here you see the implant is inserted, and you see the implant, also the bony wall, is fully intact. So it's like a bathtub. So then often I don't use a membrane, I just fill it up. That's what we have done, and you see that here. It's very easy to take that bone. The bone is from the surroundings. You take a scraper and grab it and put it in. And then of course you take bios and overfill it. And then you close it up. So that's the primary closure. You see the old fillings of that lady, the old amalgam filling. I told the dentist that before you do that, the implant crown, please exchange the filling. So get this amalgam out. In Switzerland, amalgam is completely out. I don't know if you still use amalgam here in Vietnam. In the dental school in Bern, it was abandoned in '92, a long time ago. But we still have a lot of patients with amalgam fillings. Even I had a lot of amalgam fillings when I was a young kid, lots of caries at that time. So then I exchanged them step by step. This is not done in one step. Very careful, because of the amalgam, you can swallow it and then you get the metal into your body. That's not good. So here you see that in 2007, 2 months post the reopening procedure, and then you see in the meantime the amalgam has been changed and the new crown has been fabricated. You see now beautifully, see the implant is doing quite well. This is a wide body, wide neck implant. That is 3 years post. Here you see the patient 2015, 11 years, that's when I did the other implant in the maxilla. And when I saw her again last Friday, so here you see actually also that a cone beam, when we took a cone beam, looked the buccal wall, fully intact. And this is the patient now at 15 years, 15 years. Of course, I did not take a cone beam now in the mandible, but you can see beautifully how stable the peri-implant bone is at this implant. Tissue level implant, machined neck. That's very low risk for peri-implant pathology. 15 years, patient's now 76 or so. Okay, now I'll show you the next case. This case has been extracted in private office. And you see the extraction was done due to a huge lesion here. And also this tooth has been removed. So this is number 6 and number 7. And when I got the patient, that was also 2006. You see it was already healed. Was a little bit a tricky patient because she's the wife of the state president of Switzerland, as a top politician. I also treated that president when he was in 1999. I know him very well now, very good friend. He's now a retired politician. Was a very, very popular politician, very nice guy. So I get the wife to treat. And I said, oh my goodness, what was the problem here? Big lesion. So, see, that's what we got. When we opened up the site, you see a huge defect, huge. So here you see, this is the defect. You see, this is a dry surface. This is SLA. This is not SL active, because SL active was initiated in about 2006 in clinical practice. So we take a lot of bone. And of course, where do we take the bone? We take the bone from here. Take the bone, retromolar, and move it a centimeter. Very easy. And then we fill up that defect. It needs to have a horizontal component here, a balcony. Otherwise, it's going to glide. And then a second layer of bios, and then the membrane. Such a bios today always stabilized with fibrin sealant. You will see in other cases. So then we put the membrane on top and we do a primary closure. This is the primary closure. For that you have to release the flap. You have to be very careful in the mandible because of the mental nerve. So you take a fresh blade, stretch the flap, and do very superficial incision. Don't go deep. When you hit the nerve, patient has a problem in the mental nerve here. So be very careful. I'm also very careful to do an incision of periosteum in the lingual aspect. I know that Istvan Urban shows that all the time, but that's very tricky. Because when you hit a blood vessel in the sublingual area, then you can get major bleeding, so be very careful. Don't do that with a blade there. Take a 2x2 and just stretch, and then you can stretch the flap a little bit. So this is the tension-free primary wound closure. So I told the patient, no, we are waiting. It's a big defect, we'll see. Okay, and you see what we got. At that time, this is 3 months here. 3 months, still submerged. I told the lady, I do not see too much of new bone formation. We got to wait. It will take longer, big defect. So patient came in at 5 months, still submerged. And you're going to see a little improvement, but still not perfect. Then I told her, I remember Professor Schenk, my teacher in bone regeneration, always said, if you want to foster the remodeling, you have to functionally load. So I told the lady, let's open it up and put a provisional crown on top to get the functional load. And you see now what happens, you see? This is 2 months later, provisional crown, and the bone starts to show up in the radiograph. So this is 7 months. Good. Okay. So then I send patient back to private office. She got a final restoration. And here you see the patient at 5 years, 2009, 10 years ago. So it looks pretty good. I told the lady at that time already, this is our next candidate. This is the second premolar that I don't know how long it will last. So that's 5 years later, the tooth is still in place. So actually pretty good. These are the radiographs I showed you before. That's how we started. Then before we put the implant in, this is then the 3 months post. Now have a look here, 5 years. It's amazing. That's Mother Nature. So the remodeling has completely brought back the mineralization in the bone. So the bone is now mineralized. So it looks like normal now. So I was really pleased to see that. How much the Mother Nature has remodeled that bone. So now the defect is completely gone. Okay, now look this one, 12 years. 12 years. The tooth is still in place. Do you see that? Here. Why do I have a radiograph? You see, of course, the periapical I would always take, you see, but the patient came back to me to get a sinus graft here. Then I said, yeah, then we need a cone beam, and then let's take a cone beam 6 by 6, so I also check the implant below. That's always nice. Look this one. This is the implant at 12 years. So the implant has an excellent facial wall, lingual wall, fully embedded in bone. That's how we want to have it. So that was 2016. Guess what happened? She lost the second premolar. I promised you that will not last forever. So then this was removed. That is the 17. So now a patient comes back to me, and the private dentist had extracted number 5. So then what could we do? You see, open up the site and have a direct look at the bone. So this is the implant where we have had this huge defect. We took a biopsy, we put an implant in here, and we have done, of course, here in this implant site, a new bone augmentation procedure. And also, here you see beautifully how this implant is fully covered by bone. And remember how much exposure we had there. So we have done an augmentation, membrane on top, closed it up. In the meantime, she's now restored. I have not seen her for a while. I see her from time to time at social events. But then, of course, I cannot check her implant. But I have to recall her if she was being restored in private office and to document the case to the end. Because now this is 15 years following implant placement at first hand. So this is a very nice long-term case to be documented. Okay, now late placement. Late placement is done when an implant patient comes in and had an extraction 5 years ago. Then he's fully atrophic. And that's a case I want to show you. He's a veterinary doctor. I know him very well because when I was a student, he was in the medical school, but he became a veterinary doctor then, you see. And he told me that this tooth has been removed about 3 years ago. And he felt that there's no need to get an implant. But then 3 years later, he said, damn, this tooth gap is really disturbing me. Can you help me? So then he was referred to us. And you see when he came in, you see it was heavily atrophied, not too much keratinization. When you look at the periapical, then you see this typical sign here. When it's atrophied, then you see often these like bubbles in the radiograph. That's not a good sign. The good thing is that he has an adjacent tooth to the distal and one to the mesial. So there the bone is white because of the root. In the middle is atrophied. And that's exactly what I found. We opened up and you see it was heavily atrophied. So here you see the implant bed was prepared, and you see that on the lingual, the bone height is perfect. On the buccal, it's reduced, and it's a thin wall. So what I take then, and this was done almost 10 years ago, we take the bone down, the wall, because this bone is going to resolve when we leave it, because avascular necrosis. And then you get a lot of osteoclastic activity to get rid of that bone. You don't want to have osteoclasts in your site, you want to have osteoblasts. So I take it off and create a balcony, as you can see. And then we open up the marrow, perforate, like Swiss cheese. We take, of course, here in the back, autogenous bone chips. Very important. So you put an implant in and use the autogenous bone to the buccal to fill up that defect. So that's what you see here. Healing cap on top, and you fill up the whole defect. See, this is the autogenous bone from the patient, from here. You move it 1 centimeter across. And then we stabilize it. This is the fibrin sealant. You see that here. Fibrinogen and thrombin. And it's called TIS seal. It's a Baxter Travel company from Massachusetts. It's a European product. They bought it in Austria. Austrian product. Very nice. I know this product for 35 years. When I was a postdoc, we used it in extraction sites when patients had an anticoagulation problem. Patients without any of the blood factors you see for the coagulation. Then we use this product. It immediately coagulates. So, boom, stabilizes. Okay, then comes a second layer, IOS, low substitution filler, and fibrin sealant or TIS on top. As you can see, it's the shiny, whitish color. And then the membrane on top. Double layer technique. And the closure on top. So we have everything covered up. Here you see that the reopening implant is well integrated. I'm sure at that time we have been waiting 3 months because it's almost 15 years ago that we have done that surgery. And you see, then the case was restored. Here you see in 2008, the 3-year follow-up, radiograph looks excellent. Good. Then I saw the patient again at 5 years, 2010. So good home care, as you can see here, not too much keratinization, just about 1.5 millimeter. Look the bone, very stable, no problem. So I told my friend, can I take a cone beam just to document the buccal aspect? So he agreed. So that is the implant. You see, it's a very happy implant. It's smiling face. And look the buccal plate. The buccal plate fully intact. And you remember how much defect we had. And you remember we had a balcony type defect. to stabilize the bone grafts, so they cannot glide down. Okay, so this is a quite interesting implant. I have not seen that patient now for a while. I have to recall it because it would be 14 years. In 2020, it would be then 15 years. It will be a very nice time point to see him again. So he's in private office. They are maintained in private office. Good, let me summarize. We are doing quite fine. Okay, the conclusion. So, when we do the posterior sides, don't compromise on that buccal aspect. When there is a lack of bone, then rebuild the bone. When you cannot get rid of it by shortening the crest, using a smaller diameter, then go for the GPR. It's not as often as we did it in 10 years ago. We have improved there. But of course, when there is a need for a GPR procedure, I don't hesitate to do the GPR procedure. It works very well. We use most often the early placement when there is fresh extraction site. But we also use the early placement with 4 months. As I showed you, and then we try to do socket grafting to bypass the GPR. Now when we go back to early placement in aesthetic sites, I have put together a video clip. Now let's see, can you give me the sound? Because it has a sound. I want to show you this in detail. That's not my sound. It should be a speaker. Let me see if my laptop has to be turned on. Ah, that's right. But this should be okay. So we try again. Yeah. Good.
Yeah. And a wide band of keratinized mucosa. The mirror view shows well-maintained papillae.
This case is on the ITI.
The incision is performed
on the ITI platform. It's an ITI video from Bern that I gave them to the ITI to be used.
The blade is introduced deep into the socket towards the inner.
Can you increase the sound?
To allow mobilization of the soft tissues inside the socket as part of the full thickness flap.
Leave it like this.
A sulcular incision is extended around the canine, followed by a papilla-based incision between the canine and the first premolar. The vertical releasing incision is applied as a distal line angle incision at the first premolar. The elevation of a triangular is initiated in the distal corner.
Only one releasing incision. Here at the first premolar. It is
carefully carried out with a fine papilla periosteal.
And you see we try to grab the tissue inside the socket as part of the flap.
The soft tissue inside the socket is mobilized with a spoon-shaped curette and moved to the facial aspect, thereby loosening the flap in the edentulous area. This is done very carefully to optimize the thickness of the flap in this area. It's important to debride the surgical field to have good visual access and to ensure the elimination of soft tissue remnants from the socket. The mucosa on the palatal aspect is also
very important. You see that you also mobilize the flap a little bit to the palate to check the height of the palatal wall. Normally the palatal wall is very thick, and that's very good. Because when you put a bone level implant in, the shoulder has to be below the crest on the palatal side, subcrestally located. Very important. Okay, now you see that the width of the crest, mesially and distally, is more than enough to place an implant. This is a lateral incisor site. So this case will get a narrow diameter bone level implant, also 3.3 millimeter bone level implant, because it's a lateral incisor. This surgery was done more than 5 years ago, so roughly 5 years ago. I remember very well. The lady came and told me, you see, that she has a problem. Actually, this patient is the role model of the animation video I showed you. It was copied from the company from this two-dimensional video, as you see now. And she told me that she had a fistula, external root resorption, and she told me that October 2nd she's going to have